So the objectives of today are to explain the value and the need for advanced care planning and to recognise some of the legal principles, and that's what I'll be covering. And then Mary's going to follow me up with how to actually do that in practice. The title of my part of the talk is Advanced Care Planning, Do You Really Know What Your Patient Wants? And it emphasises the point of advanced care planning for general practice staff, all health professionals, and the importance of knowing what the preferences of our patients are. We know that far too many patients approach the end of their life without adequate awareness of what their options are for medical care. So advanced care planning is about providing a structure to support the conversation about those issues, and it can start as a discussion among patients, families and support people around what type of health care they desire. And this may be the trigger to empower them to advocate for this type of care. As local healthcare providers, we're in a great position to know our patients, their families, their values, and in addition, we're generally seen as trusted and empathetic professionals by our patients, and that allows for an open conversation. So, what is advanced care planning? This is the official definition, but basically what it does is assist people to consider, discuss and document their goals and values and preferences regarding future health care, including what they see as acceptable treatments and outcomes and things that they would not want. So it's about preparation, opening the dialogue, starting the conversation for people to consider their future health. And it doesn't need to be done in one conversation. It's a process that can be built upon and reviewed and updated regularly. Oh, I love it, it's working. It's also about respecting the rights of an individual to decide how decisions are to be made. For some people, advanced care planning is important as it gives them an element of control over their health and decision making and to maintain that their voice is being heard. And for others, they'll be motivated by family and loved ones wanting to decrease stress and decision making burdens for families at a time when emotions are generally quite high. If we look at a more modern interpretation of duty of care, to take reasonable steps, which is as other reasonable doctors would do. Now I know we're nurses here, but generally the medical decisions will be made by the doctors, but the doctors will be guided by many other people, including the nurses that know their patients very well. And what this means is that if a doctor was challenged and ended up in court having to defend their actions, what they could do is line up an expert witness who will attest to the fact that they did what other doctors would do and what is a reasonable thing to do. So it's to take reasonable steps to save or prolong life and to act in the patient's best interests. And the best way of identifying what a patient's best interests are is to know what that patient would want. And if they have lost the ability to tell us, that's where it's useful to have done an advanced care plan. In other words, find out in advance what sort of care the patient would or would not want and take that into account when making decisions. I possibly should have said this before I started, but in your packs, which you have on the table there, there's a pre-session survey. And if you wouldn't mind just filling that out, because we're going to ask you to do a post-session survey as well to see whether we've made any impact on your knowledge. There are spare packs at the front if there's not one on the table for you. Hello. Oh, there we go. It's underscored by the ethical principles of autonomy, so this is decision making, and particularly around informed consent. Every person in this room would know that no doctor or nurse or health professional should do anything to anyone without getting their consent. So you consider, is the treatment useful? And treatment can only be offered if it is of medical benefit. So we're going to look at what the evidence is. And this is an article that was produced following a research project. And there's a lot of evidence to support advanced care planning. And part of that evidence has come from this randomised controlled trial conducted at the Austin Hospital. And they were looking at the impact of advanced care planning on end-of-life care of about 300 elderly patients. Patients over the age of 80 who came into hospital with general medical or cardiology or respiratory problems. And they were randomised into normal care or normal care plus an advanced care planning discussion from a trained nurse with the patient and the family. And those discussions were about what the person would want. Do they have a good understanding of their condition? Do they know what the treatment options are? And have they thought about who they would want to make decisions for them if they've lost the ability to tell us? So it's more about identifying the outcome or the unacceptable outcome rather than going through a shopping list of conditions that you may need to talk about. We've thought about the quality of care for the patients and their care needs, and the literature has also considered the impact of advanced care planning for the families, so specifically for families whose loved ones have completed an advanced care plan and clearly articulated their values and beliefs. And those families involved have lower rates of post-traumatic stress disorder, anxiety and depression after the patient's death compared with the control group. And you can imagine the decisions that are being asked of patients' loved ones during an emotional time are easily made when they've had these discussions early. So what are the benefits? Think about your own experience, either as a patient or with a loved one, and your own situation. Who would you choose to be your substitute decision maker? And does that person know what your values are and how you would want to be cared for if you could not tell us yourself? It is important that if a person's been appointed using a statutory document for medical decision making, that that person is talked to regarding medical treatment decisions and that they are known as the substitute decision maker. And Mary's going to go into this a lot more in the second session. But remember, the agent only becomes relevant when the person loses the ability to communicate their healthcare wishes for themselves. So they can have all this in place, but it only comes into play if they're unable to communicate their wishes. So the key components of an advanced care plan for the individual ideally results in identification of a clear substitute decision maker to decrease confusion in a medical emergency. This assists in decreasing possible conflict within the family, and a discussion of the person's values, wishes and beliefs to guide the substitute decision maker. And these are ideally documented and copies given to the key people. And when documented, these can be powerful statements to guide a person's substitute decision maker and the loved ones. As you would know, medical decision making is based on the best interests test. And the first question is the proposed treatment medically indicated? And this applies whether we're thinking of ventilation or dialysis or surgery. And we need to consider the medical condition, the prognosis and acceptable outcomes. And remember that a doctor's not obliged to provide or continue treatment that is not in the person's best interest, even if the patient and the family request it. It's all about benefits versus burdens. And if a treatment becomes overly burdensome, or if the burden outweighs the benefit, then it's reasonable to withhold or withdraw a treatment. A doctor's responsibility is to work out what is medically indicated and then offer that to the patient or the family if the patient is not competent. And then it's the responsibility of the patient, if they are competent, or the family, to choose from what's being offered. It's not about families and patients considering all available treatments, because of course treatment offered should only be that of medical benefit. Remember also the patient's right to refuse treatment which is offered, even if that refusal is likely to lead to an earlier death. And we emphasise this point especially. The question's never whether the patient's life is worthwhile, but whether the treatment is worthwhile. So we're just going to do a very quick case study, just to give you a sense of what this is about. This is a real case of Alfred. He was an 81-year-old man living with his wife, and he was diagnosed with lung fibrosis in July of 2004. He wasn't responding to the steroids, and the breathlessness and oxygen dependency were getting worse. He was introduced to advanced care planning at this stage, but he declined it. He said, I don't want to talk about that stuff, I'm going to get better. But after subsequent readmissions, he was approached again in 2005, and this time he said he could see he wasn't getting any better and that he had had time to think about his preferences. Particularly, he said, I don't want a tube in my throat and I don't want to go to intensive care or have any further treatment. So, what did he do? He had a discussion about his wishes with his GP, and these were documented on the discussion card. He didn't identify a substitute decision maker or complete any other documentation. When he subsequently became breathless at home, he asked his wife to call the GP rather than the ambulance as he would have done previously. His GP attended and he received comfort care, and he died at home surrounded by family and friends. And the reason why we present this case is because it illustrates several things. You can see that it's in fact not about the documentation and it's not about legalities, it's about the discussion. His wishes and values were clearly stated and relied upon, and the discussion was informed through an understanding of the law, and the discussion plan clarifies and refines what the person wants and does not want. By supporting this man to have the discussion with his family and his GP, it completely changed what would have happened to him. Who gives consent? A patient is assumed to have capacity unless proven otherwise. Capacity is required to complete an enduring power of attorney for medical treatment and to have that conversation. For the person to be able to appoint a MAPOA, medical enduring power of attorney, they need to be competent. If we're confident that the patient has capacity to understand, then we can assist them to complete that. But you don't need to complete a standardised cognitive assessment. If the general practitioner or the nurse thinks the patient has decision-making capacity, according to the above criteria, after discussion and with the knowledge of the patient, this is valid. So in summary, who gives consent? For non-competent patients, the treating practitioner must identify a substitute decision maker and discuss the benefits and burdens with them. And there's a responsible person hierarchy, and in your packs we've given you lots of handouts, but there are also some resources up here on the counter. There's a take control book which is for Victorian participants, and there's also another resource from the AMA which Mary will be referring to. But the take control book has the responsible person hierarchy, but that's also in your packs. Identifying people for an advanced care plan. So how do we identify appropriate patients? It's really any patient who you think has a significant chance or may have a chance of dying in the next 12 months. And using the surprise question isn't saying that they'll definitely die, but if you wouldn't be surprised, then now's the time to talk to them about what they would want. And there are other key triggers for identifying appropriate patients for advanced care planning. So consider a change in condition. I won't read through all those, but The most important one of those is if the person raises it. The person brings up the idea of their future care is a perfect time. And anyone over 65 would be considered an ideal candidate. This slide is about the trajectories of decline, and it can also inform who and when you would have a discussion with people. So most patients will decline along one of those trajectories, and if not a rapid decline, such as in late or advanced cancer, a patient may be experiencing a slow decline, presenting heart failure or an exacerbation of COPD. Not going to pretend I know how to use this, but you can see them. And if they're experiencing an exacerbation of COPD or multiple chronic health conditions and then they recover, you can say something like, "It's great to see you've done so well. Let's have a discussion about if you get sick again, and you can give me a bit of a sense of what you want at that time." So these trajectories are ideal opportunities to be having the advanced care planning discussion. Choosing the words to frame the discussion, we would suggest they should always be framed in the positive. So we need to think carefully about the words we use. And it needs to be discussed in a caring and compassionate way. Families want to know that they're doing their best for their loved ones, and patients can fear an unknown future of pain and suffering. Be very clear that advanced care planning is not euthanasia. I've been to a lot of advanced care planning talks and events and workshops and conversations, and always in the audience will be somebody who wants to talk about euthanasia, so that fear is out there, that advanced care planning could involve euthanasia, and that's definitely not what it's about. Allow a natural death versus do not resuscitate. They're three words that could change a life. And misconceptions about CPR need to be dispelled. There's a resource that the AMA produced, which we've got just a few copies of here, but it's available online, and it gives plain English explanations of various health conditions and gives you wording on how to start the conversation and how to explain conditions to patients. I recommend you have a look at those. Australia's a culturally diverse country. I'm not telling you anything you don't know. One way of developing skills in cultural competence is by using this 5-step cross-cultural framework. You consider your own cultural beliefs and values about illness, treatment and death. And it's difficult to define the differences within a culture. And the differences are probably greater within a culture than between other cultures. But be aware of and don't adhere to cultural stereotypes. Don't presume to know. Engage the person and ask. Ask their perspective of how they would like their medical decisions made if they're unable to make them themselves. And that facilitates autonomy and family decision making. We also need to consider our own culture, beliefs and values about illness, treatment and death, and focus on the individual person, not to assume but to inquire. So with advanced care planning, make sure you allow time to listen and reflect on what the person has said. Check that they understand what you have said to them and that you understand what they have said to you. Clearly document the person's wishes and make time to review or update the person's advanced care plan. Yes?
How much time would you allocate?
Well, I'm glad you asked that question. That's a really good question. We're going to show you a video of a GP having a discussion with a patient. And when you see the video, it looks like he sits back, he's got a pina colada, she's got a drink, there's an umbrella. They take all the time in the world. 6 minutes is all it took to go through the entire 5 steps that Mary will take you through. So 6 minutes is enough time to have a good long conversation, give some information for the patient to take back home with them and consider, and then you make a longer appointment for that person to come back. And this is where Mary's going to talk to you about how you implement this in your daily practice. So I'm about to wrap up. I'm getting the nod as well. So in conclusion, the main objective is about having the conversation with people, determining their wishes, values and beliefs to assist us in providing person-centred healthcare through their healthcare journey. While we have focused on the over 65, advanced care planning could be considered for any adult, so that we talk to and review our patients' values and beliefs at all stages of life. In your packs, you've got a resource sheet, a couple of resource sheets from Decision Assist. They have a telephone advisory service on advanced care planning, which is open from 8 to 8, 7 days a week. And they also have a palliative care helpline, which is open 24/7, and you can ring them and there's a specialist there that can help you with palliative care advice. I have to show you references, but this is in your pack. You've got a handout in your pack, and there's another. And the reason I have to show you those is that we now go blank and the next talk comes up. So thank you very much for your attention.